Okay, so chapter 3 is called Clinical Assessment, Diagnosis, and Research in Psychopathology. So, in this chapter, we're going to talk about how we end up coming to the conclusions we come to whenever a client seeks psychotherapy. So, first off, we always have to have a clinical assessment. And the purpose of the clinical assessment is to help understand the individual person, to also predict their behavior, to plan what their treatment methods will be, and to evaluate treatment outcomes. So, when we think about how we assess psychological disorders, we really need to think of it like a funnel. So, we're going to start with broad things, and then we're going to go down to multidimensional approaches and then narrow it to a specific problem. And when we start to look at how we assess a disorder, we always have to keep three things in mind. We've got to look at how reliable, how valid, and and if we have used standardization to come up with our assessment. Reliability, you might remember from your general psych course, is consistency in measurement. So we want to have retest reliability and inter-rater reliability. So when we give a test, it doesn't matter if we give it today or tomorrow, the results should be consistent. Or I like to call reliability repeatability. If it happens again, will the results be the same? And we know if an assessment is reliable when we get the same results. A valid assessment is whether or not a test is over what it's supposed to be over. Does it measure what it's supposed to measure? And there are different types of validity we can have as well. And those things can relate to, can this help us predict something? If I'm giving you a test over abnormal psychology, you want the content on the test to be valid. If I gave you a test over statistics, I don't think you would like that. And you would say, this is not a valid assessment. And then standardization refers to whether or not the technique used can be consistently used. Whenever we standardize a test, we use a population that's going to be representative of the population who will actually take the test later, because we've got to compare the two groups. And we want to make sure that our standards for scoring the assessment are appropriate. So whenever there's an assessment, we first have to standardize it. So we need a representative sample of future test takers who help us create the test. So if you think back to when you took the SAT test or the ACT test, if you took those tests were standardized, meaning other people of your same age took them first to know whether or not the questions were good questions to ask to your age group. Another thing we do whenever we're trying to determine psychopathology is we have to start with a clinical interview. Okay, this is the most common clinical assessment measure. It can be structured, it can be semi structured. And what happens is during a clinical interview, that's when the clinician tries to gather as much data as they can about the patient. It could range from half an hour, or it could be, over 4 hours, depending on whatever the patient needs and what the purpose of the assessment is. Longer assessments are typically necessary for some research studies whenever people are trying to get a psychological history, like, previous diagnoses, or if somebody has a lengthy record of mental illnesses. In a structured clinical interview, people are asked the exact same questions in the same order. If an interview is semi structured, which is most common, there's usually an outline of questions that can be followed, but there's flexibility, so I can switch it up and realize that, hey, maybe I need to ask something a different way. Additionally, during the clinical interview, we also have a mental status exam, and that's where the clinician will look at how does the person's what is the person's appearance? What do they look like? What are some behaviors? What are some of the things they're saying? What is their mood or affect? How are they functioning intellectually? What's going on with are they having any sensory responses? And then also, is there anything physical that I notice that could be of concern? When it comes to sensorium, that's like the patient's overall orientation. Do they know where they are? Do they know what they're doing? Are they aware in the present? For the physical exam, that's kind of like assessing their mental health because many patients will often go to their primary care doctor first, and they go to their primary care doctor who looks at whether their panic attacks are the result of something medical or whether it's something that's more psychological in nature. So the physical exam is not necessarily conducted in an outpatient clinic or anything like that. They're more commonly conducted in inpatient settings or hospital settings where mental illness could impact physical functioning. So, like when people have substance use disorders or eating disorders or somatic symptom disorders, and they're taking medication for with lots of side effects, we want to be able to get that physical exam so we'll know if anything is going on that could impact their physical functioning. On this slide, you guys can kind of see some of the components that might exist on a mental status exam. So we're going to look at, the appearance and behavior, thoughts, mood and affect, intellectual functioning, and sensorium. And, and then over here on the other side, you can kind of see what that might look like. We also are going to look at behavior and observe what's going on. In a person's behavior. So, are they focused on the present, on the here and now? The whole purpose of the behavioral assessment is to identify any type of problematic behaviors and situations the client might be experiencing. And when we look at behaviors, it's important to look at antecedents, behaviors, and consequences. So, those ABCs of behavioral assessment. Behavioral observation and assessment can also either be formal or informal. It can follow those structured questions, or it can veer off just a little bit. The patient can also discuss, things that they've noticed at home on their own, and the clinician can also make some behavioral observation. And then there's also the problem of reactivity, which is using direct observation when your behavior is being observed by yourself or someone else. We know that through the problem of reactivity, that sometimes people will change their behavior, especially if they know they're being watched. When it comes to psychological testing, there are a few tests that can be done to help determine level of functioning. But of course, when we have that psychological testing, we need it to be reliable, we need it to be valid. Many projective tests, such as things like the Rorschach test or the thematic apperception test, those are rooted in psychoanalytic tradition. They're often used to try to assess things that might be unconscious to us or outside of our full awareness. It can tell us things about a person's personality, but they can be ambiguous and they're going to have multiple answers. So it's going to require a lot of inferencing when it comes to scoring. So when we think about these types of tests, which here's an example of an ink blot um, from the Rorschach ink blot test. So all of you can look at this right now and see something different. And there are some answers that are considered more acceptable and some that are considered more pathological. So the reliability and validity of tests like this tend to be mixed because, how do we determine what is considered an appropriate test? An objective test is another way to make some determinations about personality. And when we think about objective tests, we're thinking about tests like the MMPI, and these tests are rooted in empirical tradition. They're going to be more true false or things that are on a Likert scale. They're less ambiguous because they're having you choose an answer, and there's not a lot of inferencing or guessing that has to take place when the test is scored because the test already has criteria for scoring depending on the answers someone gives. And then we also have IQ tests. So IQ tests are developed as a measure to determine what people know based on their age group. They were first developed to determine the intellectual functioning of children. And, over time, it was eventually adapted to also work for adults. There are verbal and performance domains on psychological tests, which compare a person's score against the scores of others in their same age group. So when we think about IQ tests, we're thinking about tests like the Wechsler Adult Intelligence Scale for adults, starting at 16 years and about 7 months, and then the Wechsler Intelligence Scale for children, which starts at about 6 years of age and goes to about, a few months after turning 16. We also can have neuropsychological testing, and the purpose of neuropsychological testing is to assess broad ranges of skills and abilities and to understand how the brain is functioning and impacting behavioral relations. So we're talking about tests such as the Luria Nebraska test or the Halstead Wrighton batteries, and these all can help determine brain damage and test a number of different skills. We also have the clock drawing test, um, the Stroop test, and a number of other tests that can also tell us about intellectual functioning. Sometimes, though, we can have some problems with neurological testing because, what if it gives us a false positive? It shows us that there's a problem when there actually is no problem in the brain. And it can also give us false negatives when it fails to detect a problem that is actually present. So that's why it's so important to not just do one specific type of test. It's important to get a good clinical picture of what's going on with a patient. We can also have some neuroimaging conducted, which is where we take pictures of the brain so that we can understand the brain structure. We can also understand the brain's functioning. So people can participate in a CT or a CAT scan, which will show x ray images of what's going on in the brain. And then MRIs are two very popular forms of neuroimaging. And with MRIs, it's going to show high resolution scans. And, even if we do a functional MRI, it's going to even give us more information. It's going to tell us what changes in brain activity have taken place. We also have PET scans and SPECT scans as well, and these both involve injection of radioactive isotopes, and they will, show a chemical reaction in areas that have been affected after the injection. We can also have psychophysiological assessments, and these are assessments that are going to look at brain structure, function, and activity of the nervous system. So we're talking about things like an EEG, which will show us the different brain waves. Um, we can also look at heart rate and respiration to show a cardiorespiratory activity, as well as electrodermal response levels and activity that's taking place within the sweat glands. Continued for psychophysiological assessments. We're going to use these anytime we have disorders that involve a strong physiological component. So, sleep disorders, for example, those EEGs are critical for sleep disorders. Also, disorders like PTSD, sexual dysfunctions, and people who have headaches and hypertension. We can utilize some of those psychophysiological assessments to determine what exactly is taking place in their brain. When it comes to diagnosing psychological disorders, we want to look at classification as the main component, because the way the DSM works is disorders have been classified. So there's assignment to categories of disorders that are based on shared attributes and shared relations. So as we start to classify our clients, we have to think of different strategies for how we can characterize them. The autographic strategy says that we have to look at things that are unique to the person, including their cultural background, their circumstances, and their personality. Because let's face it, if we don't take culture into consideration, we could diagnose somebody with something that they don't really have. We also have to look at nomothetic strategies, which is when we identify a specific psychological disorder and we're trying to make a diagnosis. We want to determine general classes and common attributes that are shared between a number of people who might have those same features. So we can also look at taxonomy, which is how we classify things in a scientific context. We can also look at nosology, which is the taxonomy in psychological and medical contexts, as well as nomenclature, which is what helps us label those nosological systems like panic disorder and depressive disorder. We can also look at the categorical and dimensional approaches to classifying disorders. So if we look at a classical approach, then we're going to look at the fact that if it's classical or categorical, there are strict categories that people must fit into, like either you have social anxiety disorder or you don't have social anxiety disorder. And when we look at a dimensional approach, that's when we're able to classify the dimensions of a disorder and realize that different people can have varying amounts of a disorder. And then a prototypical approach looks at combining both those classical and dimensional views to come up with a diagnosis. So we know that the DSM is the book that we use to diagnose psychological disorders. It's typically updated every 10 to 20 years. The last version of the DSM was created in May of 2013, and that's the DSM 5. Before the DSM 5, we had the DSM 4 TR. And currently, researchers with the American Psychiatric Association, because that's who creates the book, they are currently working on the revised version of the DSM 5. Because if we think about it, we've got to update the DSM whenever society changes, whenever the things we're going through are greatly affected. And I would say since 2013, it's been about 9 years, so probably around next year, sometime in the spring or the year after, we'll have a new DSM or a revised version of the DSM, because let's just face it, our society has changed so much in the last 10 years. Within the DSM, we also have the ICD-10, which is the International Classification of Diseases, which is published by the World Health Organization. So if we think about the history of the DSM, prior to 1980, diagnoses were made based on biological or psychoanalytic theory. And then in 1980, the DSM-3 really changed and revolutionized how we classify disorders. It relied on symptoms, and it tried to improve reliability and validity. There became a 5-axis diagnosis for how we look at problems in multiple ways. Then in 1994, we had the DSM 4, which eliminated some of the previous distinctions between psychological and organic mental disorders and started to reflect on the appreciation of disorders that are influenced by both psychological and biological factors. And then there was also a revised version of the DSM 4, which included some new research and changed some of the criteria for what it takes to have a psychological disorder. And then we have the DSM 5, which is what we currently use. And the DSM 5 ended up taking away that multi axis system that was created with the DSM 3 to include inclusive or exclusive criteria for disorders under broad headings. And it's much more empirically grounded and a prototypical approach to classification of disorders. So, one of the issues that really hasn't been resolved with the DSM 5 that could be addressed in the DSM 5 version that is currently being worked on is the problem of comorbidity. Comorbidity happens when a person has more than one psychological disorder happening at the same time. So, if a person is experiencing depression and anxiety, those would be comorbid disorders. And we know that it's common for people to have more than one psychological disorder at a time. And being able to address those things can help us improve the reliability of our diagnoses, and we could artificially split the diagnoses that are kind of similar. So, and there are some disorders that are kind of similar in some of their criteria. Another unresolved issue in the DSM 5 is with dimensional classification. So, the DSM was intended to move towards a more dimensional approach. But many people think that it's not that different from the DSM 4. Some labels within the psychological community still have a lot of negative connotations. And because of those labels and those stigmas, they may make patients less likely to seek treatment. I really don't know if that's something we can address through a book. It's more of having society educated to help us with those things. So, to summarize, clinical assessments are the whole aim of them is to fully understand the client, to understand what is causing human suffering. And we want those clinical assessments to be reliable, valid, and standardized. Now, let's switch gears a little bit and talk about how we conduct research in psychopathology. So, first off, we're going to look at some questions that drive the science of psychopathology. What problems cause distress or impair functioning? Why do people behave in unusual ways? And how can we help people behave in more adaptive ways? So, first, we need to think about the basic components of research. When we're getting ready to research something, we first have to start with a hypothesis or an educated guess. And sometimes we can't test our hypothesis, but we can formulate them in a way so that they are testable when we're looking at psychology as a science. So we also have to consider how we're going to design our research, and that means how can we test our hypothesis. In psychology, we're always going to have an independent variable and a dependent variable. The independent variable is going to always be the variable that causes or influences the behavior. So if there's a drug in the study, then it's always the drug. And the dependent variable is going to be what happens as a result of the independent variable, because it depends on the independent variable. So what change has been impacted by whatever is being studied. When we look at our research designs, we also have to consider validity. Internal validity has to do with the extent to which results of the study are due to the independent variable. External validity has to do with the extent to which the results of the study are generalizable to the population it's studying. So, does it fit the independent variable, and does it apply to the population as a whole? Whenever we want to increase internal validity, we've got to look at minimizing confounding variables. And those are going to be the things that we really can't control. So, other things that could impact our study. So, one way we can minimize confounding variables is to use a control group, which is a comparison group that has a similar composition to the group that's actually being studied. So, if we had a study of anxiety treatment, we could compare anxious patients who are treated with a medication with patients who do not receive any medication. And then we would have a experimental group and a control group. You also can use random assignment. So once I have my two groups, I can randomly put them in my experimental or control group for comparison purposes. And I can use analog models, which is where I recreate a phenomenon under study in actual laboratory conditions. When conducting research, we also want to look at statistical methods. And that is a branch of mathematics that helps us protect against bias when we're evaluating things. We have to look at statistical versus clinical significance. Statistical significance is, are the results of the study due to chance? And clinical significance are the results clinically meaningful? What do they say to us about how we look at disorders? And how does it matter for us? And when we have statistical significance, that does not necessarily mean that it's clinically significant. So just because it's due to chance doesn't mean it makes meaning to us from a psychological perspective. For example, if we had a group of 1,000 people who were suffering from insomnia, if there was a new intervention that helped all of them sleep an additional 10 minutes per night, that would probably be statistically significant. But for any of them, the difference between 5 hours of sleep and 5 hours and 10 minutes of sleep won't necessarily make much difference from a clinical standpoint in how they're able to function on a day-to-day basis. We also have to look at how we balance statistical versus clinical significance. So we have to look at the effect size and social validity to determine, okay, is this something that really matters to us from a pathological perspective? We have to look at patient uniformity, the myth that says researchers sometimes mistakenly see all participants as one homogeneous group and mistakenly believes that their groups are as equal as they can be when they actually aren't. We also have to look at generalizability, a hard word for me to say, which is the extent to which the results are applicable to the larger population. Because when we do a study, we want this information to be applicable to society at large. So if we're looking at individual cases of people, we can look at the case study method, which is how we observe one person or a group of people in detail. And this was kind of the foundation of how historically we looked at pathology. We looked at it from person to person or group to group as a whole. But the thing with case studies is sometimes they can lack scientific rigor. We know that we can't generalize the information we find from a case study to the general population. So that internal validity is typically very weak. And there also can be a number of confounding variables that could take place in the study. When we use correlational research, we look at the relationship that might exist between two variables. Can having a higher level of education, is that related to or linked to higher levels of income? So the nature of correlation is looking at the statistical relation between two or more variables. There's no manipulation of an independent variable. And correlations can range from -1 to +1, and they can be positive or negative. So we're looking at how much two things relate to each other. Correlational research can be necessary in situations where manipulation can occur, but it can also be limited because whenever we have correlational research, all we can say is that two things are related. We can't say that one causes another. And we also can't say that when this happens, we're going to always have this next thing happen. When we think of epidemiological research, an example of that would be the correlational method. So if we look at things over time, we can look at how much of an instance we've had of something, how prevalent something has been, and look at the course of the disorders. So, for example, when we look at how we treat AIDS and trauma following a disaster, we want to look at that over time. Here's an example of what a positive correlational research study would look like. Both variables are going to go up. In a negative correlation, both variables are going to go down. And when there's no correlation, there won't be a pattern. So in the positive correlation, as people grow older, they tend to have more sleep problems. So age increases, sleep problems increase. And then for a negative correlation, as people grow older, they tend to have fewer sleep problems. So age increase, but sleep problems go down. And then for no correlation, there's no relationship between age or sleep when things are just all over the place and it doesn't follow a pattern. And then, of course, the most important part to us as psychologists when it comes to research is the experimental research. And this is when we manipulate an independent variable and we actually can make causal relationships. And we can say that things have happened due to cause and effect. And the way we do that is by having an experimental design with a control group, a group that we compare to our experimental group. This group is probably going to get a placebo, which is an inactive treatment like a sugar pill, which they think that they're getting the actual treatment when they aren't. And it's better when in our experimental research, we have double-blind studies where participants are unaware and the researcher is unaware of who is in which group. If you watch the show Grey's Anatomy and you think back to Meredith's trial where she was trying to study Alzheimer's disease, and Richard Weber's wife was participating in the study, and her study was supposed to be double blind, and she wasn't supposed to know who was getting the actual treatment and who was getting a placebo, and she tainted the results of her study by purposely giving Richard Weber's wife the actual drug because she wanted her to get the treatment. But we know from an ethical standpoint that taints the results of the study because now she knew anything she saw would impact her thinking, oh, my drug is working or it isn't working. So when we have a double blind study, we need the participant not to know who's getting treatment as well as the researcher. We can have comparative treatment designs in experimental research as well. And this is when we have a group design where we compare different forms of treatment in different people and people who we believe are similar. And that can help us address treatment processes and treatment outcome. We can have a single subject design, which is where we study a single case with under different experimental conditions and times. We repeat it. We look at variability and levels and trends, and we look at internal validity. We can also have within a single subject design, we have to look at how withdrawal affects our study because that happens when we stop treatment to see if behavioral symptoms return the way they were before treatment. We can also have multiple baseline designs where we start treatment at different times at different conditions at home versus at school and see if the changes occur in conjunction with the introduction of treatment. So this happens a lot, especially when it comes to ADHD medication and parents who give their children medication at home and at school, and then they stop in the summer. And they can notice the difference in whether or not the medication is actually happening, it working the way they want it to. We can also look at behavioral or genetic research studies and strategies. So, when we look at behavioral genetics, we're looking at how our genes impact our experiences and our behavior. So, we have to consider phenotype and genotype. Your phenotype being those observable characteristics that people can see, like your eye color, your height, and then your genotype would be your genetic makeup and things that you necessarily can't see. Strategies that we use in genetic research is we can look at family studies where we look at the behaviors and the emotions and the traits of members of a particular family. We can also look at adoptee studies where we separate environmental and genetic factors. So we take twins and we put them in different environments. We can also look at the psychopathology in fraternal versus identical twins and make some assertions about them. And we can look at genetic linkage and association studies where we look at different genetic defects and how they can impact us. So, the rationale and overview of how we study behavior over time is us looking at how does the problem or behavioral or the behavior that we're looking at change over time? Is it important in the prevention and treatment of research? So when we study behavior over time, we can look at cross-sectional designs, longitudinal designs, and sequential designs, and they can help us see if people have changed over varying periods of time. When we think about cross cultural research, we know that cross cultural research can be important to us because it helps us overcome different ethno centric research concerns. So, it can also help us understand different people of the same culture. We can also look at assets and liabilities. And assets would be how do we clarify psychopathology manifestations in different ethnic groups. And we can also look at problems with the cross-cultural cultural research, which tells us that it can be limited by available measures. So when we look at programs of research, we have to look at interrelated research questions. We have to draw on several methodologies in answering questions, and we can conduct our research in stages that often involve replication. So replication is critical whenever we are doing research because it protects us against flukes, and it lets us know that when we conducted a research study, it wasn't just something that happened once. It's something that is true because we can repeat it over time. Whenever research is conducted, we also have to consider different ethical considerations. So the IRB, or the Institutional Review Board, and the APA Code of Ethics has certain policies that must be followed whenever we have research with human subjects. And they make sure that research and data are handled responsibly. And here are some of the ethical principles they guide for us. They said you must get informed consent. You must get the person's permission to do research with them. You must be competent, and the person must be competent, and they must be able to give their consent. So if they, have a memory disorder or something like that, are they competent? Participating in a research study must be voluntary. You can't just coerce people to do it. You can offer compensation, but that's not coercion. Coercion is you have to do this or else. You have to get all of their information so that you can make an informed decision. And we have to look at comprehension, like understanding the benefits and risk of participation. So, to summarize, when we think about research methods, we have to be able to establish and test hypotheses. And how we do that is going to vary depending on the questions we ask. And each different research design can have unique benefits and drawbacks. And when we think about abnormal psychology as a whole, it's founded in the scientific method. It helps us understand the nature of abnormality and human suffering. It helps us understand the causes of psychological disorders and how the course of a disorder can go. It helps us understand how to treat and prevent psychological disorders in the future. And when it comes to replication, replication is necessary for a research study because when we do that, we know that our study worked and it wasn't a fluke, it wasn't due to chance. Replication is the cornerstone of science and programmatic research, and it helps us keep things in context. And being able to follow those ethical considerations and values are also very important to making sure that we have a good research study. So I know that was a lot of information, but I hope it helped you understand some of what you read for this week.